Her family was told it was Alzheimer's. Her neurologist had already begun the conversation about memory care facilities. Her daughter was researching what the next 2 years might look like. And this woman, who had spent her entire life being the sharp one, the one who remembered every birthday and never needed to write a grocery list, was quietly disappearing. But it was not Alzheimer's. It was her medications. And within 4 months of identifying the problem and making carefully supervised changes, she was coming back, reading again, recognizing faces again, laughing at the right moments again. This is not a rare miracle. This is a medically documented pattern happening to seniors every single day. And the people it is happening to are almost never told that their medications could be the cause. Today I am going to walk you through 9 categories of common medications scientifically linked to memory loss, cognitive decline, and dementia-like symptoms in adults over 60. I will explain what each one does inside the aging brain, what the research shows, and what questions you should be asking your doctor. Before we begin, I am not telling you to stop any medication. Do not make any changes without speaking to your physician first. What I am giving you is knowledge that may start a conversation that changes everything. Number 9. Diphenhydramine. If you have Benadryl in your cabinet, a PM pain reliever, or any over-the-counter sleep aid, you are likely taking diphenhydramine regularly. It feels harmless. The package says sleep aid. Most people assume over-the-counter means safe for long-term use. It belongs to a class of drugs called anticholinergics, drugs that block a neurotransmitter called acetylcholine. Acetylcholine is your brain's primary chemical messenger for forming memories and staying alert. In a brain over 60, acetylcholine is already naturally declining. Blocking more of it nightly produces measurable cognitive effects. A study in the Journal of the American Geriatric Society found regular users faced substantially elevated risk of cognitive decline with visible changes on brain scans. Diphenhydramine appears in dozens of products. Any label saying nighttime, PM, or sleep formula almost certainly contains it. Check your labels. Number 8. Proton pump inhibitors. Omeprazole, lansoprazole, pantoprazole, Prilosec, Prevacid, Protonix. Among the most prescribed medications in the world. The problem almost no one mentions: your stomach acid is responsible for absorbing vitamin B12. Proton pump inhibitors dramatically reduce stomach acid. Long-term use compromises B12 absorption, and B12 deficiency is clinically linked to memory impairment and cognitive decline. The pattern is so similar to early Alzheimer's that the two are sometimes confused even by experienced physicians. A 2016 study in JAMA Neurology examining over 73,000 adults found long-term users had a 44% higher risk of developing dementia. Most PPIs were designed for 8 to 12 weeks of use. Many people have been on them for years. Ask your doctor about tapering, get your B12 levels tested, and ask whether dietary changes might reduce your dependence. Number 7. Bladder control medications. Oxybutynin is one of the most commonly prescribed medications for overactive bladder and one of the strongest anticholinergic medications still in widespread use. It crosses the blood-brain barrier and directly interferes with the same systems responsible for memory and learning. A 2019 study in the British Medical Journal found seniors using strong anticholinergics like oxybutynin for more than 1 year had a 49% higher risk of dementia. Studies also show measurable volume reduction in the hippocampus, the brain's memory center. This is a structural change, not just temporary fogginess. Newer options like mirabegron work through a different mechanism with dramatically less cognitive risk. If you are taking oxybutynin and have noticed memory changes, that conversation needs to happen with your doctor. Number 6. benzodiazepines, Valium, Ativan, Klonopin, Xanax. For the right person at the right time, these medications provided real relief. The concern is what research shows about long-term use in adults over 60. A study tracking over 8,000 seniors found those using benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease. When GABA is chronically overactivated, the brain reduces its own natural activity. Neuroplasticity deteriorates, memory encoding slows. Never stop benzodiazepines abruptly. This can be medically dangerous. Any reduction must be a slow, supervised taper with your physician. Alternatives include buspirone for anxiety and cognitive behavioral therapy for insomnia, which research consistently shows is more effective long-term than medication. Number 5. Statins. Statins save lives, and for many patients with cardiovascular disease, the benefit clearly outweighs the risk. But there is a nuance most patients are never given. The FDA updated statin labeling in 2012 to include warnings about memory loss and confusion after reviewing thousands of adverse event reports. Not all statins carry equal cognitive risk. Lipophilic statins, simvastatin and atorvastatin, cross the blood-brain barrier more readily. Hydrophilic statins, pravastatin and rosuvastatin, have shown significantly less cognitive impact in comparative studies. If you are on a statin and experiencing brain fog or memory changes, ask your doctor whether switching to a hydrophilic statin might provide equivalent cardiovascular protection with less cognitive impact. Number 4. Amitriptyline. Rarely prescribed as an antidepressant today, most commonly used for nerve pain, migraine prevention, and insomnia. What patients are almost never told is that amitriptyline is one of the most potently anticholinergic medications still in widespread clinical use. A landmark 2015 study in JAMA Internal Medicine, following over 3,400 adults over 10 years, found high anticholinergic exposure, with amitriptyline among the top contributors, was associated with a 54% greater risk of dementia. The damage is gradual and invisible. Word-finding difficulties, slowed thinking, each symptom attributed to aging for years before anyone considers the medication. Safer alternatives for nerve pain include duloxetine and gabapentin. For sleep, low-dose doxepin. For mood, modern SSRIs. The options exist. Number 3. Antipsychotics. This one I need you to hear carefully because it happens every day in nursing homes and assisted living facilities, and most families never find out. Antipsychotics were developed for schizophrenia and bipolar disorder with psychosis. Today they are routinely prescribed off-label to elderly patients who are confused, restless, or simply difficult to manage, not because they have psychosis, but because their behavior is challenging. The FDA issued a black box warning about this practice years ago, citing increased risk of death in elderly patients with dementia-related behaviors given antipsychotics. A 2022 study in The Lancet, tracking over 25,000 older adults, found seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even without a prior dementia diagnosis. If a loved one in a care facility is being prescribed quetiapine or risperidone for behavioral reasons, you are entitled to ask, why is this prescribed? What is the plan to discontinue it? What non-pharmaceutical approaches have been tried? Those questions deserve clear answers. Number 2. Paroxetine. Paroxetine, sold as Paxil, is classified as an SSRI, the same family as Prozac, Zoloft, and Lexapro. That classification creates a false sense of safety. Unlike every other SSRI, paroxetine has significant anticholinergic activity. While sertraline and escitalopram leave acetylcholine largely undisturbed, paroxetine interferes with it in a way that resembles the older tricyclic antidepressants. A 2021 review found elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year, declines not seen with other SSRIs. The American Geriatric Society has placed paroxetine on the Beers criteria, the official list of medications considered potentially inappropriate for older adults. If you are over 60 and taking Paxil, ask whether sertraline or escitalopram might offer equivalent benefit without the cognitive burden. Number 1. Anticholinergic polypharmacy. This is not a single medication. This is what happens when multiple medications interact, and it may be the most important thing I say in this video. The average American over 65 takes 4 or more prescription medications daily. Many take 6 to 10, prescribed by multiple physicians who may not have full visibility into each other's prescriptions. When several carry anticholinergic properties, they do not simply add together. Research suggests the effects can multiply. A 2022 analysis tracking over 280,000 older adults found that those with the highest anticholinergic burden had a 120% increased risk of developing dementia over 10 years. Double the normal risk. From pills. Pills, most of them were never once warned about in terms of cognitive risk. Consider a 70-year-old woman. She takes a PM sleep aid. She takes oxybutynin for her bladder. She takes amitriptyline for nerve pain. And she takes an over-the-counter antacid every morning. 3 of those 4 are anticholinergic, each prescribed by a different provider, each appropriate for its individual purpose, none of them aware of the others. And not one doctor, not one pharmacist has done the full calculation on her behalf. This is not hypothetical. This is what polypharmacy looks like every day. Here's the most important thing I can tell you. Drug-induced cognitive decline is often reversible. When the medication burden is identified and reduced under proper supervision, many patients experience meaningful recovery of mental clarity. Memory returns, the fog lifts. Your brain is adaptive, it is resilient, it is capable of recovery when given the right conditions. Here is your action plan. Step 1. Write down everything you take, every prescription, every over-the-counter product, every supplement. Step 2. Search for the Anticholinergic Cognitive Burden Scale online. It is free, publicly available, and scores medications by cognitive risk. Look up everything on your list. Step 3. Schedule a medication review appointment with your primary care physician. Use those words exactly. Step 4. Ask specifically about deprescribing, the supervised process of tapering off medications that carry unacceptable risk relative to their benefit. Step 5. If your physician is dismissive, get a second opinion. A geriatric pharmacist can perform a comprehensive medication review focused specifically on cognitive risk. 1 in 3 seniors over 65 will experience some form of cognitive decline, but not all of it is inevitable. Not all of it is Alzheimer's. Not all of it is irreversible. Some of it is sitting in a medicine cabinet right now, quietly doing its work. The most powerful thing you can do today is know what you are taking, understand what it does, and ask the questions that the system was not designed to ask on your behalf. If this video gave you something important, share it with one person, a family member, a friend who takes multiple medications and has been told their memory lapses are just part of getting older. You might be the reason they start asking the right questions. Subscribe for more evidence-based health content made for adults over 60. And leave a comment below. Which medication on this list surprised you the most? I read every comment. Your brain is worth protecting. And now you have the knowledge to start